Hey, and here we go. Here we go. This is this. I keep saying that over again. This is This Week in Pharmacy. I'm Todd Urey. Welcome to This Week in Pharmacy. My goodness gracious, it's October 18th, 2024. I feel like we're sprinting to the end of 2024 with accelerated speed. I need somebody to slow it down. But we have so much to talk about. I'm going to jump right into this. My goodness, like so much is happening. I can't wait to share with you. Everybody's heard of iHeart Media, iHeart Radio, I'm sure. We are partnering and joining forces with the iHeart Media Ruby division, RUBY Ruby division, and their coverage of a very entertaining podcast called Symptomatic, a medical mystery podcast. And we're going to be doing some roundtable discussions on this podcast, specifically some of these episodes. Episode case number 19, Jose came out, and I want everyone to go listen to the Symptomatic podcast because I think pharmacists should hear more on these symptoms and staying ahead of it and being able to guess. And let's make a discussion about this. But I'm excited to be a part of this. I'm excited that the Pharmacy Podcast Network is a part of it and that we get to talk about Symptomatic. I'm excited about that. Hey, we have a ton of content coming in from the Pharmacy Podcast Nation, from our teams, from people that are dedicated to moving our profession forward. We just released the very first episode of the Cardinal Health Counter Talk podcast covering the RBC 2024 event. The reason why this is such a special event is because I wasn't even there this year, and it shows you the expansion of our network and our coverage. Dr. Adam Robinson took the mic. He was the host. And we had another host, Nicole McClure from Finch Marketing and GRX Marketing. This entire series, it's a 3-part series, was brought to us by Retail My Meds and the Cardinal Health Counter Talk podcast. I'm just excited to see that we're growing. We have other people covering national events, and it's just exciting to see that we're actually expanding like that, and Cardinal Health is a big part of it. All right, World Pharmacist Day was covered by the PharmExcel podcast with Katrina Azur. She's over in New Zealand. She's one of the healthcare technology leaders in New Zealand, looked to as a PGX specialist, pharmacogenomics. And she goes in the definitions of pharmacy stories of preventing the pharmacy evolution, of the role of pharmacy and diversity, and just want you to read down through and listen to World Pharmacist Day with Katrina. It's a special episode, so don't miss it. All right, our new publication partner, PTMR, from the Lockwoods, from the original magazine that they put out was Computer Talk, and they are evolving. And Maggie Lockwood and team has submitted their first episode through the network, The Power of Personalized Medication Management. It's a really interesting discussion with Hamad Shah, who's the CEO of Clearest Health. And he has a lot to share with regards to challenges of traditional pharmacy models. We know that pharmacy is changing and how the role of the pharmacist is going to be much more treatment driven than in the dispensing side. I think the dispensing side is going to almost all but disappear from the future of pharmacy. From a pharmacist perspective, that is. I think automation and technology are going to take care of a lot of that. I think the pharmacist is going to be able to just dial into the patient's record and seeing what's going on and seeing if everything that they're coded for from their physician. But we can talk about that later. CPHT Connect, the Certified Pharmacy Technician Connect from the NPTA. The guys over there at the NPTA are just amazing. They've joined the Pharmacy Podcast Network. Shout out to Mike Johnston and Ashley for all of their support and how excited we are. All right, Mark Garofoli, give him a shout out. The pain guy is back, and he wants to talk about topical pain medications. Bringing up topical pain medications is our partnership with Ural Pharma. Ural Pharma does a lidocaine patch, and they're going to be involved with the coverage that we're doing for the National Community Pharmacists Association. And I'm so excited to be working with Ural and Real Value RX, which is our secondary wholesaler, very powerful secondary wholesaler, and Happier at Home. And then, of course, IPC, which is just, we have more to talk about IPC in just a minute. All right, let's get into today's news. I tell you what, a lot is shifting with pharmacy. A lot is happening in the PBM space. And one of the issues that we're coming up with from Clear Health and covering this just came out on October 18th today, is by Marion Mass and David Balat. And David and Marion are two amazing supporters of PBM reform, but they do it from a data analytics perspective as consultants. And they write a article called Warped by Washington. America's medical supply is in crisis again. David is going to be on a special episode of TWIRx, and we're going to be covering that with him next week. But I had an awesome conversation with him, so we're staging that conversation to share with you. And this article, you have to read this article. I'm going to put this link in the show notes. That we are really, multiple crises are taking place. Pharmacy deserts are expanding. And now, of course, we're having major supply issues. So take a read of the Real Clear Health and link up with Marion, Dr. Marion Mass and David Balat. David can be found on Twitter as well as Marion can, and they're amazing resources. Big news. CVS outs its CEO for sluggish growth and spooky investors. Karen is out. Karen Lynch, and what's taken place and allowing it to happen 5 years ago or 10 years ago or whenever they started into the way that PBMs were acting and sucking up as much profit as possible. It had nothing to do with healthcare. We know that. But CVS Health has abruptly ousted its chief executive officer, Karen Lynch, on Friday as the pharmacy and healthcare conglomerate struggle with sluggish growth and face pressures from investors. Well, I'm going to tell those investors to go pound salt because you're part of the problem. I'm sorry, but you are. I think that everybody that owns CVS stock that is in pharmacy, that is in healthcare, should sell that stock, get rid of it, take your money and go do something else or invest in some other stock, just to show them that what they did to the PBM industry and how they sucked up profits and didn't put enough of it back into its pharmacy stores. We've lost 8,000 pharmacies. They've closed 1,200 more coming from Walgreens, and just the trickle amplified effect of the dominoes falling so hard because of practices in healthcare, just from a greedy perspective. So I'm glad to see Karen go, but I'm not super excited about the future of CVS because I think, once again, it says that the investors are pushing pressure on CVS to what? Keep the juices flowing, right? Keep the money, keep the profit flowing. And that's it. So this is the worst part of this line, in my opinion, is that facing pressures from the investors. Okay. So really, if you really start taking the model, this model is just about giving the investors their money. It doesn't have to do with healthcare. And I think that's a fundamental issue that we're just going to, it doesn't matter who they pick as a CEO. It really doesn't, because it's just going to keep happening until they reinvent the model. By the way, they're not going back the way that it was. I guarantee they're not going back. And it's unfortunate, but a lot of people are going to have to lose their jobs, including Mr. Joyner, who is taking over for right now, like being the interim CEO. Mr. Joyner taking over for Karen Lynch. Big news in pharmacy land. This article is out from the CT Insider, and this is the CT Insider business section, the Connecticut Insider. It says, overbuilt in Connecticut. Experts explain why CVS, Rite Aid, and Walgreens are in for tough times. But the funny thing is about these articles, they act like this just came and happened. And when you read down through the experts, they say about conditions and closing the pharmacies and Chapter 11 for Rite Aid, and they're ousting Karen Lynch for David Joyner, and they're just going through the motions. They're not really digging in, saying, when did this effect start to when did the cancer in the pharmacy profession start to destroy our profession, to harden the hearts of our pharmacists and our technicians who were suffering in the stores without support, were being treated like fast food people, fast food medicine, fast food store workers, paying them just to shovel out medication as quickly as possible just to make a profit. And I'm not impressed with some of the reporting that comes out, because they don't really dig down into the true meaning. There's a line here that says, overbuilt in Connecticut, the plethora of closings has some retail and healthcare experts predicting Connecticut could begin to see what are known as pharmacy deserts. Duh. And it says more than 16 million people live in the pharmacy deserts, according to trade publication Pharmacy Times. Shout out to Pharmacy Times. A pharmacy desert is defined as where the suburban resident with a car live more than 2 miles from the nearest pharmacy, and individuals in rural areas live more than 10 miles from the nearest pharmacy. And in some cases, it's bigger and longer than that. In 2019, a Cardinal Health report on rural pharmacy deserts found that 2,177 rural towns with populations between 500 and 5,000 did not have access to a pharmacy within 10 miles. That's crazy. And so to take a look, Google CT Insider, CVS pharmacy. And it's a good article. I just think that it's very surface. It's not really digging down into the whys. All right, next up, USA Today reports more pharmacy closures leave consumers in pharmacy deserts without access to medications. Betty Lynn Fisher reports and writes a really good overview of how pharmacy technicians are losing their jobs, pharmacists are losing their jobs, they're closing the stores, it's impacting communities, it's impacting health, it's impacting public health, and keeping, pharmacy is sometimes the only healthcare provider that someone has access to. And like I said, I've said this before on other TWIRx, this is get worse before it gets better. We know that. The independent pharmacy that's open right now has to fortify itself and find ways of making cash-based businesses. There are ways to do that. Shout out to Happier at Home, all cash-based care, nursing home care, right in your home. Home care organizations franchise that partners with pharmacy, understands community pharmacy. Debbie Marcello and team. But take a look at this article in USA Today and understand their take on the reason that this is taking place and why are pharmacies closing. They say that pharmacies aren't being paid enough to stay open and make a profit, especially true for independent pharmacies that are in the areas with high numbers of Medicaid and Medicare patients. Let's stop there for a second. Medicaid and Medicare attaches itself to tax funding. So what is the most frustrating is when the bulky Karen Lynches walk away with parachutes of billions and billions of dollars, and the money that organization makes, maybe she has a parachute that's only millions of dollars. But nonetheless, she's fat, she's happy, she's not technically fat. But she just walks away. Her stockholders are still waiting for them to be able to make money again, because that's what it said in the last article. It's all about that investor money, isn't it? No, being serious, dump your CVS Health stock or you're part of the problem. That's just what it comes down to, really. Aetna, I think you need to dump the stock. Optum, dump it. CVS Health, dump the stock. Dump it. Dump your stock. If you own stock in it, shame on you. You're part of the problem. You are. You might be a pharmacist that just got laid off from Walgreens because they're shutting out stores, and you own PBM stock, PBM organization stock. I didn't say Walgreens. Walgreens isn't in that. That's not who I would say to dump it. I would say keep it, because I think they're going to survive. They're going to make it through somehow, some way, but they don't own a PBM. That's what I'm saying. That's my opinion. Hey, I want to give you some news from LinkedIn, which is, I'm on LinkedIn every day. And if you're not on LinkedIn, you should be on LinkedIn, because you get so much insight from the insiders. Mark Asenza, president and CEO of IPC, he reports on North Carolina independent pharmacies are folding as prescription prices soar. Where's the money? Well, you went over the first article, didn't we? About those investors sucking up their investment money. It's just crazy. All right. Just want to give a shout out to our Perfecting Peds team, led by Lyle and Jenna and Mary. They're going to HLTH. So are we. We're going to be covering HLTH Health 2024, along with these amazing news organizations, Bloomberg and Business Insider and CNBC and Fierce Health, Healthcare IT Today and Forbes, Hit Like a Girl Pod, and Pharmacy Podcast Network. It's exciting to see so many organizations showing up. We're excited for sure to be there. We can't wait to talk to all the interviews that we have lined up at Health. That is the place where digital health is moving forward. People are coming together and collaborating about digital health specifically. We're going to be at the IPC booth 4240. We're going to be talking about how digital health is helping community pharmacy move forward with all of the issues that it's experiencing, and real world answers, not fluffy stuff. Definitely world. If you're not on LinkedIn, I encourage you to. If you are on LinkedIn, please send me a request. Absolutely love LinkedIn. I'm on it multiple times per day. It's a great news source for us internally, and it's a nice place to be able to network. HLTH, then we get back from HLTH, I think on Wednesday of next week. This is going to be October 20th through 23rd. Then on the 26th, we head out to Columbus for the Growth, Performance, and Success event of the year, the Super Bowl of Independent Community Pharmacy, the National Community Pharmacist Association, the NCPA 2024. If you're going to this event, please reach out to us. Let us know you're going to be there. We'd like to get a quote from you. We are excited about the future of pharmacy, even though it's treacherous and it's going to be rough. It's not going to be all easy street, but I'll tell you what, there is new profits to be made in healthcare services delivered by community pharmacy, all cash based. Those programs are out there. We cannot wait to tell you what's coming from our organization. And I've hinted at it before. I got my Drug Life pin on from the team over at Keycentrix. I love that design, and we are living the drug life, aren't we? But I want to get into our interviews. We have two great interviews. We're going to be talking with a leader in news, in healthcare news, and overall news from U.S. News and World Report. And then we're going to be digging into a little bit on the PBM analysis information coming from Dr. Joey Mattingly. Without further ado, let's get our first guest in here. Hey, and on This Week in Pharmacy, we are so proud of the work that Perfecting Peds has been doing throughout the nation in teaming up with health systems and hospitals to dial into the needs of kids, our littlest of humans, and brand new born babies and babies that have been there for treatment, regardless of what it is. That team who develops our podcast, which is the Pediatric Pharmacist Review. If you haven't heard of this show, just go out to the network, go to your pharmacy podcast network, your favorite player, and scroll down until you find this episode that just came out just last week, October 7th, changing the game and how pediatric pharmacists are really dialing in to help change the game and enhance the medical practice in aligning themselves with pediatricians and really becoming the right hand of treatment. So I'm excited what's happening in 2025. The growth of our network has brought us amazing interviews and resources and data sources. Data sources is the key word there. And something that I'm extremely proud of and excited about to bring This Week in Pharmacy is we're going to be talking with the team lead at US News, managing editor, and we're going to be dialing into sources of information, sources of data, specifically around evaluating Children's Hospital. I'd like to welcome Ben Harder to the show on This Week in Pharmacy. Ben, it's so good to have you here.
Thank you so much, Todd. It's great to be here.
All right. When I learned of this, a shout out to Sarah, your team member. She's amazing in helping to coordinate this meeting. You're running crazy. This is the busiest month we've been at. We've been at 3 pharmacy conferences. One is around specialty pharmacy. Pediatrics was there. The next will be HLTH, which is the big collaborative conference out in Vegas. And then the last will be the National Community Pharmacists Association. So each of those sectors are very interested in the study and the data that you've really invested in pulling out, evaluating children's hospitals. So I'm fascinated by this. How many years has US News been evaluating children's hospitals?
We've been doing analysis of pediatric hospital care since 2007, actually, almost 20 years now. It happens that we published the first ranking of pediatric hospitals the same month that I joined US News. So I'm very privileged now to be responsible for overseeing that project. And I work with a great team, both within US News and our research contractor, an organization called RTI International, to survey and gather data related to pediatric care and then produce the rankings that we publish each year as best children's hospitals.
All right. So dialing into that data and the health analysis team, how you're determining which hospitals are labeled best and that qualification of that, like how's that work?
Yeah, so we start from the perspective of the patient or family in all of the evaluations that we do of hospitals, and we evaluate hospitals and maternity care in several dozen adult services as well. But in the focus on pediatrics, we look at 11 different areas of pediatric specialty care. And so those range from pediatric cancer to congenital heart disease to pediatric orthopedics and neonatology and so on. This year, we actually added a specialty, and we could talk about this later, behavioral health, pediatric and adolescent behavioral health. So there are 11 specialties this year. And the reason that we look at hospitals through the lens of the specialty area is that the right hospital for a child with cancer may not be the right hospital for a child who's born with a heart defect. And in fact, maybe they're best off going to a hospital that only provides care for pediatric cancer patients, and it may not even be a hospital that provides services in other specialties. So that's why we've developed a methodology for evaluating pediatric hospitals in each of these different 11 specialty areas.
Ben, this is important because now you're able to go out there to the public based on data and based on analysis and pull in some of our future physicians and future specialists and future pharmacists that are so fascinated specifically with pediatrics and children's hospital and association and research, the realm of HLTH and digital health and how AI is going to have a big accelerator on data usage. So this kind of all ties back into before I go to the next question, how many pediatric specialists or specialties does US News evaluate? And why did you pick those ones?
Yeah, we publish 11 specialty rankings, but I want to be clear that we actually cover more specialties than that because some of those rankings encompass multiple pediatric disciplines. For example, congenital heart involves care provided by both congenital heart surgeons and pediatric cardiologists, as well as pediatric critical care and obviously anesthesia for the surgeries, and of course pharmacists. So we know that every child needs a multidisciplinary team, and the way that we've approached evaluating children's hospitals is to focus on those, on those sort of specialty areas where there is a whole organization approach to taking care of patients who have similar needs clinically.
So it kind of makes me think about the evaluation of each of them, the data that you're providing. So why did US News feel it was important to evaluate behavioral health programs and how these children's hospitals were kind of tied in to regarding their behavioral health offerings specifically for children?
Yes, so we've seen the mental health crisis in adolescents and children only worsen over the course of the pandemic and coming out of the pandemic, and so that was definitely a prime motivator for us in bringing that specialty into the fold of what US News evaluates. But even before the pandemic, we were hearing from pediatric healthcare leaders that given the paucity of resources for behavioral health and the growing need, even prior to the disruption of the pandemic, for more access to pediatric, specialized care for behavioral health needs and mental health needs, that it was an important area for US News to shine a light on. They recognize that they, as organizations, as a sector of healthcare, weren't necessarily able to provide the level of access and the level of care that patients and families deserved, and so they wanted US News to address that by looking at it, by examining that specialty area, and obviously we publish best children's hospitals. Our focus is to highlight those that are really excelling, but by doing so, we're also highlighting the challenges that other organizations face. And so that was also a motivator for us. Again, everything we do comes back to and keeps the patient and the family at the center. And so thinking about what does a family need if they have a child with a developmental disorder, or with suicidality, or with some complex behavioral health needs that are going to require the kind of care that a health system can offer. And so that was the motivator and the centrality of our approach.
Ben, you and I are old enough to remember in our upbringings, and I was raised in kind of a very strict family. I was one of 5 children, 3 boys and 2 girls, and the 3 boys came first. And my father was extremely disciplinarian, and my realm of mental health was just do it and stop complaining. And you're not dealing with the stresses, and you're not dealing with learning how to even recognize mental health issues. And it was kind of swept under the rug. So when I experienced in my own children things that they were going through, one of my daughters with selective mutism, and how that was impairing her ability to learn in school, and how the school now dials into children that they can recognize what the issues are and make such slight and gentle adjustments to how they're involving them in the education and in the classroom to keep them included. It's brilliant. And if I would have if we would have had this during our stressful times in 2nd grade and 6th grade and 8th grade, it could have, helped us. So when I see you dialing into behavioral health, that's exciting, because it's the number one healthcare professional touching patients more than anyone is the pharmacist, because of how much they're in contact. And if we can just dial into getting pharmacists to slow down a little bit and spend more time with the psychotropic behaviors and the ADHD and what kids are going through, and just slow it down a bit, this is the kind of data that can change medicine. So I'm just blown away by the depth of this information. And I also want to understand, what is the honor roll list? Like, what makes these hospitals the best of the best?
Yeah. So in addition to the 11 specialty rankings, in each of those specialties, we identify 50 children's hospitals that we determine to be the best in the country in that specialty area. But we also publish an honor roll of 10 hospitals each year that excel across really all of those specialties. And so they tend to rank among the best in all 11 of the specialties. And that's been our tool for really shining a light on organizations that provide both an impressive depth and breadth of excellence in pediatric care. And so for a child in need of really almost any form of healthcare, these organizations are knocking it out of the park. These hospitals, and often these are hospitals surrounded by all of the services, from pharmacy to primary care. They're really kind of integrated healthcare delivery systems focused on pediatric care and doing an exceptionally good job at it. And so we hold up these 10 hospitals on our honor roll as exemplars of excellence in pediatric care. But they are exemplars, and there are other hospitals that are really outstanding in one or more of the specialties that we evaluate as well.
What about the themes, Ben? Are there any top pediatric hospitals on your honor roll list in specific themes?
Yeah, I mean, one theme that we were looking for this year, we didn't know what we would find, was how did the honor roll hospitals of the past do with the new specialty that we added, behavioral health, pediatric and adolescent behavioral health. And excellence in one area of care doesn't necessarily predict excellence in another area of care. And that's something we see, in my example earlier, of the hospitals that are best at pediatric cancer may not be the same as those that are best at treating another specialty. But one thing that jumped out at us was that the honor roll hospitals that have excelled in these various pure sort of medical and surgical specialties over the years also excelled in providing behavioral health to young patients. So I think that just sort of speaks to the consistency with which an excellent organization, really, to be excellent, they have to have the right culture, they have to have the right team, they have to have the right integration of different disciplines. It's not, we call it medicine, but it's not just medicine, right? It's nursing, it's pharmacy, it's psychology in the case of behavioral health. All of these and many more disciplines need to work together: physical therapy, occupational therapy, and so on. And so I think that was the lesson. We didn't know what we would find when we began developing the new ranking in behavioral health this year, but I guess I'm not surprised that it turns out that being good at providing, say, surgical care is a reasonably good predictor of how good a hospital is at providing care in other areas like developmental health.
Listeners, go to usnews.com or go to the health section. Look up the honor roll of US News Best Children's Hospitals 2024-2025. I'm going to have this link in the show notes. So if you're driving, if you're jogging, if you're doing something, don't worry about it. It's going to be in the show notes. Just take a look down there. I'm going to have a link to this specific report. Every once in a while, Ben, we'd like to have you back, and let's dial into specific subjects that we believe pharmacists could really have an impact on. And we definitely know pediatrician specialists and pediatric specialist pharmacists are going to rise, especially when we start dialing into some of these metrics that you're also providing. And if you have a specialist on your team that's dialed in specifically to pediatrics, it's just one other team member in the HCP roundtable to surround our children with better healthcare. So this is special, and we very much appreciate you being here today on This Week in Pharmacy.
Well, thank you. I'm so glad to be here.
All right. Once again, a shout out to Perfecting Peds and your work out there, just fighting and just giving so much support and information to pediatricians across the nation. Jennifer Quinn, Dr. Quinn, and your team, we very much appreciate you. Ben, we have to have you back on the show. We've loved having you here, and we hope you have a great rest of your October. October is Pharmacist Month, by the way.
I'm so glad to hear that, and I hope your listeners do have a good October. I guess it's appropriate that our Best Children's Hospitals rankings came out earlier this month.
That's right. There we go. All right, Ben. Thanks so much.
All right. Thank you, Todd.
This is Debbie Marcello, host of the Happier at Home PRN podcast. Did you ever consider all of the potential cash revenue that you're giving away? What if you were to learn about services and products that you could keep in-house as opposed to referring your customers out? On my podcast, Happier at Home PRN, learn from the experts who have expanded their services to increase revenue, earn out-of-pocket payments, all while increasing the quality of care in their community. Listen to our past podcasts and join us for future episodes where we focus on growing your pharmacy into a thriving business. And we're not talking about keeping your head above water. We're talking about wealth and the survival of your pharmacy.
Hey, and then this, and on this week in pharmacy, boy, I tell you what, when you try to do things live, even at my experience, been doing this for 15 years, you will mess up. Just keep going. Just for anybody that's starting a podcast, just keep going, keep going, keep going. All right, on this week in pharmacy, I'm going to get that again for the third time. You know, there's people, and can't wait to bring them in, but I just can't believe how many generations, even in the 20 years that I've been in pharmacy, how things seem to go through cycles and things are starting to change. And I look to people that have been soaking in the data and the knowledge, the pharma economics of it all, to understand the truth about behind the scenes, behind the hyperboil, and we get angry at PBMs. Someone that I have a tremendous amount of respect for, and his constant research as a representation as being a professional and a pharmacist, is Dr. Joey Mattingly. And I'm so excited to finally have you here, Joey.
Yeah, it's great to be here. And like I said, we go back a while, so it's kind of fun to finally jump on the pod.
Well, I'm excited to have you. I tell you what, you have been increasingly quoted lately. You actually took part in a subcommittee antitrust that I loved your quote, and I'm going to just subquote you. And you said, hey, if a pharmacist dispenses a medication, ABC, NDC number, whatever, and they get paid, great. If the pharmacist does work, consult, talks with the patient, sets them down, medication review, let's dial in, figure out what's going on. It takes 15 minutes, 20 minutes, 30 minutes of description. And all of a sudden the pharmacist's like, time out. This is not the right med for you. Patient leaves, that pharmacist gets $0. And when you said that to that committee, like, I was like, where's this quote? I just want to spread this everywhere through all social media because I want people to hear that. That was amazing. I like that.
Yeah, I appreciate. Yeah, I appreciate that, man. Yeah, it took me back to my Kroger days. I thought about it when I was younger quite a bit, but it's like so much is focused on like different policy reforms that are like, we're gonna try to change payment to this and that, and it's all still drug based. You know, it's all still based on dispensing a drug, and no one's bringing up like, why does it have to be always just focused on the drug? Why aren't we paying them for their value? And again, I've just worked with a lot of amazing pharmacists that never never cared about that kind of stuff. And they just did what's best for the patient, and they kind of got punished for it.
Just got back from the National Association of Specialty Pharmacies, and about a fourth of the revenue that's being pulled through the specialty pharmacies has nothing to do with the dispensing fee. And it has to do with follow-up, and it has to do with ancillary care, and it has to do with polypharmacy, either up or down or whatever it is, and really dialing into what that patient's going through. Well, that's specialty pharmacy. When I think of our communities and I think of our independents and even our retail chain, how long is it going to take I know you don't necessarily have the exact answer, but just from what you've observed, how long is it going to take to start getting our pharmacists paid for being a consultant, for being the medication expert and dialing in without it having to be a dispensing fee?
You know, what's been hard, Todd, is over the years, you know, I do believe we've seen community pharmacy change substantially, and it's put our community pharmacists in a tough position, both chain and independent. You know, it's a lot of people think it's maybe just an independent pharmacy thing. It's like, no, it's all, you know, community pharmacies. I think what's starting to happen is, you know, in some areas where you lose the pharmacy, or you know the pharmacy or town had one pharmacy, now it has 0 pharmacies, and people are like, hey, what happened to the pharmacy? And it's like, yeah, you all undervalued it for X number of years, you know, and they hung on for so long and couldn't hang on anymore. Or, you know, I talked with one pharmacist who actually had a very profitable business and couldn't find a student to go to his remote area to buy him out, you know, and his closure, just because he was like, you know, I just can't, I've done it for 40 years. I can't do it anymore. And he you know, and he felt like you could hear the sadness in his voice when he talked about losing that pharmacy, or, you know, having that pharmacy closing its doors because he had fought for so long. And so that's why it's just complicated. I fear that it's going to be a lot of cases where we're like, you know, what is it like, where you don't recognize what you had until it's gone, kind of thing?
Yeah. Yep, exactly. Joey, I'm seeing at every conference I'm going to within the last 24 months, the rush of our independent pharmacies, who are, I would call, the stabilized ones, the ones who were able to take the punch in the face that happened to them at the beginning of 2024 with DIR fee apocalypse and all of that stuff. Mm-hmm. They are rushing to find cash-based businesses that plug into what's happening in the demographics of our entire nation. And that is the influx of our baby boomers and home care, and how now our community pharmacies are building these little mini long-term care pharmacy environments where the home is almost like the assisted living center. And now we're putting home care into it. We're putting remote patient monitoring into it. We're putting follow-up into it. Even I just talked with Dr. Chris Antipas. He has a little machine called Modesto that goes on the tabletop. And of course, it dispenses exactly in the time. It communicates with the iPhone. It communicates with the EHR. So this is exciting, but the dispensing fee is still, in some cases, the only source of income, which is pretty frustrating. Right. But these very intelligent pharmacy owners are now saying, I get paid for home care services, bathing, shopping, cleaning. I'm getting paid for durable medical equipment businesses, cash. I'm getting paid for a diabetes program or a nutritional program. There's pharmacists now doing coaching. There's even Dr. Hussein, who's the sports pharmacist, who's dialing into athletic people that are athletes that want additional help from a pharmacist. So this is going to increase. But when you soak in the pharmacoeconomics, is it the right?
Yeah. I always say health economics if I get chopped up. Yeah.
That's right. But when you're teaching, you're at the University of Utah College of Pharmacy. What data is coming in that you're saying, you know, I speak from a dreamer's perspective because it's not fully baked yet. I see some of it happening, but what are you seeing happening that's the real world, and it's the rubber that meets the road?
It's been really hard, and I've battled in terms of like, how do I help my students think forward, because I rewind the clock 15, 20 years when I was getting into pharmacy, and there were a lot of folks that were very negative about the profession when I was a pharmacy technician as well. One of the things I found is like my first year students are often more entrepreneurial than my third and fourth year students. It's like the first year students don't know what they don't know, and they haven't. I swear, I think like as in pharmacy, we sort of like strangle the entrepreneurism out of them before they graduate. And it's like, we kind of, because, you know, like I used to have a business plan competition that was with NCPA at Maryland, University of Maryland when I was there. And I remember taking first years one year. I was like, oh man, this is going to be weird. They're not going to know what to do. And dude, they had some of the most innovative stuff. Some of it was illegal because you're like, that's against the law. And they're like, oh, well, we didn't know that. And so you're like, oh, that makes more sense. Like once you learn all the laws and all the things that you can and can't do, you sort of forget to ask the question, like, why can't we do that? Why don't we do that? Right. And so I genuinely try to like challenge my students to say, like, what's the current environment? Why is it that way? Like, why are we doing it that way? So that they can hopefully break free of like, you got to do this because this is how it's always been done.
Have you ever dialed into any data, Joey, that would show you through like CMS or something, how many long-term care geriatric specialists, how many specialists, specialty pharmacies, how many community pharmacists that we have, where we can look at it and say, okay, if we have 300 and I don't know what the number is, 305,000 active or 309,000 active in the United States, you might hear on the glass half full on my side of things where I'm going to say, hey, population's expanding, we're going to need more pharmacists. Then you're going to have glass half empty people that are going to be negative and saying, we don't need any more pharmacists. I think in the new age of pharmacy care, we absolutely are going to need more pharmacists because that's not going to be 5% of the total anymore. It's going to be 10%, 20% that are going to be entrepreneurial, who are going to have their own practices and consultancies that are going to find a sweet spot that are going to be able to make money at it. I want CMS to recognize this, to start paying pharmacists for those services and get away from this dispensing fee.
Well, Todd, one of the things I'm nervous about, and I've been advocating for this since I got out of pharmacy school. I went to a state school, state university. I had good grades. I still graduated with over $200,000 in student debt after pharmacy school. And that was 2009. I got students now graduating again, $250,000. We're trying to do some things at Utah to reduce that, but it's still across the board. We got, all these students graduating with so much debt. My fear is that they don't feel free enough to risk things, right? Like for me, I was scared that I wasn't going to be able to make my student debt payments. And so I took a safer route early on and wasn't as free as and so part of me, the reason why I bring that up is that we need to also advocate and push to make education more affordable for these young people. We need colleges. And again, this might, put me out of a job, but we gotta, we can't be charging $40,000 a year for school or we need to be more efficient at the college so that these students don't graduate with so much debt that they're just stressed out paying that. They're not even thinking about being entrepreneurs. They're not even I can remember in 2009 thinking God, what would it take for me to go get a loan to buy an independent pharmacy in my hometown or something like that? I couldn't even think of that because I was so stressed out about the, nearly $250,000 that I already had in debt. How could I take on another $500,000 to try to invest in a pharmacy? So everything you're saying is absolutely right. So maybe we need to actually advocate with CMS. There's government programs for physicians in terms of loan. And I know we do have some public service loan forgiveness and some other things like that, but it would be a good investment for CMS, for Medicare, for NIH, for these different, government agencies to help invest in young clinicians so that they're not in so much debt when they get out, so that they can actually, take a chance. Maybe you don't need $100,000 a year when you get out of pharmacy school. Maybe if you actually had less debt, you could start in an entry level $60,000 a year position that's learning, growing, and then going up. If that does that make sense?
It does, because there have been independently owned pharmacies out there who have said to these PharmDs, hey, you're not going to give you a salary of $120,000. I'm going to give you a salary of $65,000, but you're going to become owner of this thing in the next 3 to 5 years or something. So there's plans and there's creativity, and as like you said, as long as it's legal, just keep doing it, and you keep dialing into what you're passionate about. I think it starts with the clinical approach. Every one of the pharmacists I've ever met in the last 22 years of doing this and being in pharmacy, brilliant, intelligent people that started with biology or chemistry and now went in and got their PharmD, and they want to do that. They want to be a pharmacist. And then all of a sudden they start to evolve, and we've seen the splintering of pharmacists that go a specific route. Shout out to Jenna Quinn. Dr. Quinn is now our pediatric pharmacist expert, and she's now known nationally that this is a track for pharmacists. So if you're a P2 and you're listening to the show right now and you love kids and you want to become a pharmacist that dials into pediatrics, that is now a thing, and it's working. Matter of fact, Perfecting Peds is out there. Maybe they have, by the time you graduate, maybe they'll have an internship or a residency or something like that. But regardless, I don't stop imagining what you want to do as a pharmacist, even if it's not necessarily pharmacy. Maybe you want to go into AI and you want to write scripts to help AI do something crazy. But I don't want our industry to lose hope because of the players that were too profit driven, and kind of they squeezed out their own young, they crushed their own young, they put their own stores out of business, and then of course they crushed the hopes of our retail pharmacists that are burnout. And that's only one. That's not our industry. That's one portion of the entire pharmacy profession. And I'm out here going to conferences and meeting with people and talking with the national associations, and I see a completely different light than what the naysayers see.
Yeah.
All right. So what research are you working on right now that has you excited? Is there anything that's happening in your world, anything that you're dialing into, any hope that's coming through your connections with legislative bodies or people that you've talked with to give us any inkling of something new or hope?
So we've got some research coming out. I think it's embargoed till November, but a little sneak peek is that we've looked at some data in Colorado that after a pharmacy closes, there's a period of time where patients kind of fall off the map, where they're not adherent to medications. There'd been some other research on cardiovascular meds, and we wanted to test it with anticonvulsants and saw some interesting data. And again, we weren't looking to see why the pharmacy closed. We're working on that too. We're having some focus groups with pharmacists and technicians who've been a part of a pharmacy closure to talk through, talk to us about what happened in the months leading up, like what happened after the fact. Because I think there's a bigger story to tell, for whatever, and this is where sometimes, everyone is definitely focused on the PBM. I totally understand that aspect and the revenue models, but regardless of why the pharmacy closes, there are ripple effects that happen for patients, for the community. I talked to one pharmacy owner who was like, yeah, my small town, we were doing pretty well. And when I had to close up shop, our town council's budget dropped by 6% or something by just sales tax alone, from that one business. And it's this is an economic story. This is a bigger, and my fear is that with all the focus solely on PBMs, that we're maybe also missing the overall evolution of the retail market, which is some of the things we got into in my testimony with Congress is we're seeing, customer demands changing. We're seeing things I just want our pharmacy community to try to respond and hopefully get out in front of some of these things as they're changing. But, it's not just independent pharmacists, because Walgreens is struggling. I think I saw CVS is going to be laying a lot of folks off too. Not that it's my point is the economy's changing for pharmacy in a different way that's possibly bigger than any one payer, and so we got to wrap our heads around it so that we can help pharmacists transition or help their pharmacies transition to meet the new customer demands over the next 10 years and that sort of thing. So I do think we have some good research coming out, but it's complicated. And the hard part, in these days, man, it's whether it's the media or in social media or whatever, a lot of times it's the headline or the one or two things. And I live in a whole world of nuance where there's it's way more complicated than one headline.
It's very true. All right, listeners, just in case you haven't heard this, I do want to play this for you. It's only about a minute long. Just 1 second.
Dr. Mattingly, you noted that the concessions that PBMs get from pharmacies are contributing to consolidation of pharmacies, essentially squeezing the independents out of the market. What could Congress do to remedy this?
when we're evaluating legislation, especially things like national average drug acquisition cost or cost plus type pricing, because I know those kind of things have been thrown out there. When we're talking about what the cost of the drug should be and the cost of the dispensing fee, we need to really understand what is the value of the service that the pharmacist is providing. When I was a pharmacist, I guess I'm still a pharmacist, but I was a real pharmacist before. I wasn't incentivized to tell the patient not to take a drug, right? Like my revenue is based on you filling a prescription. If I say, we talk and we figure out your history and it's like, hey, maybe you shouldn't take this medication, I get zero revenue. And now we swear an oath, so we do that. But maybe that shouldn't be the case. Like maybe we should figure a way for the care that I provide that I'm compensated for. And then there can be a combination of that fee for service and combination of a capitated kind of model.
Ah, my goodness. Like, I have that saved on my Twitter, and every once in a while I'll just play that for family and friends. And of course, they don't get it. And I always look at their facial expressions being like, do you get it? Do you get it? And they're like, I'm like, listen, like if a pharmacist saves your life by not letting you take a drug, they get no money. And then also my dad's like, oh, I get it.
Yeah, I got to work on the delivery too, and then I do forget that I'm still a pharmacist because I don't feel like a real pharmacist anymore. And the internet sometimes tells me I'm not a real pharmacist, so I sometimes get confused. Like, oh yeah, I'm technically still a pharmacist, but yeah, no, I need to work on the delivery because it really is. It's sad that pharmacists do turn away revenue because it's the right thing. Right. And I don't think we have the power to change that. We can change the model. We can do that. So that's kind of why I'm I'm challenging my students every day because Todd, I don't know if it'll be I hope it's in my lifetime, but by God, hopefully by the time my students get out and maybe they change the world and they get it the way it should be. But it's kind of the way I'm looking at it these days.
I think that the chickens have left the hen house in the realm of secrets that are inside a lot of the business models of PBM. So I think that there's something new coming, and I think CMS is going to react to that. I think provider status will probably accelerate as soon as we prove from a national level that, in fact, the pharmacist has something to do, and sometimes that something to do isn't about a dispensing fee. It's about, hey, I need to consult with this diabetic patient or some kind of disease state or back to the specialty realm. But I have just been thrilled by the growth of what you've done and the data that you're bringing, the continuing research that you're doing. We need more pharmacists teaching future pharmacists what was, and of course, what's coming, and what we have an opportunity to do can be new. We just need to find a way to get it paid for.
Yeah. And it is tough because I recognize that there's a lot of challenges for a lot of pharmacists who've been working for many years and kind of really in the, from a day-to-day perspective, it's got to be really tough to stay positive. And so I totally empathize with folks who've had enough and are really frustrated. It's just tough for me because I can hear those things and I still I don't look at it as what's going to be in 2024. I've got this weird, I'm a big history nerd. So I think a lot about when I'm long gone, when I think what is, 2084 going to look like, and I think that's kind of where my brain goes a lot of times. So I kind of sometimes have a hard time dwelling on what's happening right now to think let's make sure we do this the right way as we build it, because we want this to be better way beyond any one of us. But so sometimes, I definitely push back a lot on some things that are said, but I am trying to be positive. I think one person one time called me toxic positivity, which I didn't know that was a thing. So I was like, okay, so I'm apparently too positive. So I apologize to anyone listening that thinks I'm too positive, but it's just kind of who I am.
Not in the same way. And I see things working. I stopped going to the Reddit board pharmacy section because I would always get shunned. And then many of the things I used to talk about 5 or 6 years ago are now actually happening. So it's just, I think if you set your mind to something and you really apply and you think it through, I think you can get things done, even as side hustles that can become true full-time positions. And I've known so many pharmacists have gone that route that are now building their own businesses, and they had to have a full-time job in order to get there. And there was a lot of work to do in between, and it's not an impossibility. All right, are you going to be at APHA 2025?
Oh, absolutely. Yeah. The APHA has been my home since I was a student. It really helped me kind of get, even though I'm not as active as I once was. I was on the board for a period and was Speaker of the House. I was super active. I've taken a little bit of a break in terms of just my overall, but I always try to get there to be there. I just feel like you got to be there for the House of Delegates and those things if you want to. It's the one place where managed care, pharmaceutical industry, independent pharmacy, like everybody's in the room. And that's like my favorite part of it is like, we all need to be there to disagree, like it's not just there to sing Kumbaya. Like sometimes we need to like have disagreements, but it's like a family fight, like you can argue with family and then let's go, have a drink after and talk through it. So.
All right, it's in Nashville. I just got back from Nashville. I've never been to downtown Nashville, and I had such a good time with the NASP. So I'm excited to be going back, and I think this is March or April.
Oh yeah, it's typically March. I haven't looked at the final dates because sometimes it floats into that last week of March, first week of April, but I haven't looked. It's probably it's typically March though.
All right, Pharmacy Podcast Network will be running Locked on Pharmacy, which is the official podcast of the APHA. I want you to be there and just give me another quote. If anything's changed, maybe that research will have come out by then and you can actually share some of that with us. But I hope to see you in Nashville.
Yeah, looking forward to it. And for anyone who's not been to the American Pharmacists Association, whether or not you feel like it represents you, just remember it's a membership organization, meaning that the members that show up are the ones that can move the needle. And so if you're frustrated with the American Pharmacists Association, my challenge to you is like, well, let's go to Nashville. And if you don't like it, have fun and eat some hot chicken in Nashville and enjoy the time. You know what I mean? Like take a chance on going if you can make it, and hope to see you there.
The APHA 2025, Igniting Inspiration, Ignite Your Inspiration in Nashville. I'm really excited. Definitely, I want to plan to see you there, Joey. Get you, like I said, get you on the show and move the industry, move our profession forward. We'll see you. Thanks for being on this week.